All right, let's get started. Good evening, everyone. Thank you for joining me. My name is Daniel Southern, and I want to talk tonight about spine pain, the interventional orthobiologic approach. Let's dive right in. This is a fairly long presentation. The human spine is a very complicated structure. It is composed of 33 bones and 48 joints. There are 24 discs in the human spine. There are three curves, including the cervical and lumbar lordosis and the thoracic kyphosis. And the point of these curves is to distribute axial loads going up and down the spine. Um, the forces are of course greatest in the lumbar spine, the lower back. And this is why probably that the pathology is greatest in the lower back more than in the neck, much, much more than in the mid back. Tonight's presentation is going to focus uh, by default on the lumbar spine simply because this is the most common area of spine pain. But what we talk about in terms of uh, pain symptoms, in terms of treatment, applies throughout the entire spine, which is the neck, the cervical, thoracic, and lumbar spines. The spine is made up of motion segments, and we'll talk about that more later on. Motion segment consists of two vertebral bodies and the disc that separates them, along with two facet joints where the bones actually touch. Spinal function. The main function of the spine is to support the body and the limbs, to protect the spinal cord and all the nerves, and to allow for a great range of motion. Spine pathology, what can go wrong? Well, there are many, many joints, as I just told you, so arthritis is often an issue as we're aging. And because there are also many joints and many bones, instability is a problem. Again, as we age or following a trauma, and instability leads to malalignment of bones, and gravity works on the bones and the alignment, and over time, meaning many decades, can begin to distort the alignment of the spine. There can be compromise of the spinal pathways for nerves within the spine. Notably, we're talking about narrowing, which is multifactorial as we age. And the narrowing in the spine can reach a point where nerves become involved, and we call this stenosis. But disc protrusions, herniations that push back into the spinal pathways can also irritate nerves, causing sciatica and arm pain. And of course, instability. If the bones aren't locked down, if the ligaments are lax or the spine muscles are weak, the bones can move too much in relation to each other and also compromise spinal pathways, resulting in nerve pain. There can also be loss of ability to distribute forces and provide support. And this is generally the result of degeneration of the discs. The discs, remember, are large chunks of cartilage that provide cushioning to the loading forces in the spine. And then there's weakening of the bones themselves, notably osteoporosis as we age. This can compromise the ability to provide support. And then, of course, cancer. There are certain cancers that metastasize to the spine, notably renal, but prostate can metastasize to the spine, as well as others. But I'd like to begin tonight by dispelling some of the myths regarding, in particular, low back pain. But again, this applies to neck pain as well. And these are pretty prominent, and I'm sure you've heard of a few of them. The myth of the injured back. Backs are not prone to injury. As humans, we are built to labor. And the majority of back pain epidemic is due to bad habits of modern life, meaning sedentary lifestyles and not exercising enough and being out of shape. The majority of acute back sprains, regardless of how spectacular they are and how much they may debilitate you for a few days to a week, the majority of these recover fully. And never amount to much of anything in terms of long term. However, some people respond to acute episodes of crippling back pain by developing fear-avoidant behaviors, meaning that they spend the rest of their days avoiding the things that they think may have caused this horrible crippling back pain, thereby leading to a deconditioned state. And deconditioning can lead to an increased risk of injury just because of lack of support in the spine. The myth of doing too much. This is something you hear. Your grandmother tells you this often. Oh, don't do too much. You'll hurt your back. The truth is that backs hate sedentary lifestyle. So if you're just sitting around on the couch and trying to avoid hurting your back, you're probably making the situation worse. Backs respond to regular use, regular exercise, and regular activity. The myth of obesity causing back pain. This is one that was propagated by doctors several decades ago. Quite routinely, if you walked into a doctor's office complaining of back pain and you were even in the slightest overweight, it was, oh, just lose some weight and your back pain will improve. Well, we've disproved that. We've done the studies, and losing weight does not change your back pain. The goal of treatment should never be to lose weight. The goal of treatment should always be increased fitness, not weight loss. The myth of the neighbor's advice. I love this one. I've heard it so much as a doctor. A patient comes in and says, well, my neighbor has the exact same pain as I do. And they say, ... Everyone is an expert on back pain. And why do you think that is? Well, that's because everybody is going to have back pain. The lifetime prevalence of back pain is estimated to be 60 to 80% of us will have some episode of significant back pain. And because the majority of us will get through it with no residual whatsoever, we feel that whatever we did to suffer that back pain and get out of it is the thing that you should be doing if you have back pain. But I just want you to remember, your neighbor does not know your diagnosis. You do not know your neighbor's diagnosis. And your neighbor, more than likely, is not a doctor. Just keep that in mind. The myth of the MRI. The MRI of the spine anywhere rarely reveals the diagnosis, with the exception of clinically significant protrusions. MRIs should be ordered to confirm the clinical diagnosis, less to reveal the cause of spine pain. MRIs require much interpretation. That's the take home there. And they don't, despite a prevalent belief amongst civilians, indicate why somebody has chronic right or left-sided or midline back pain. This ties into the myth of the disc protrusion. Studies have shown that disc protrusions are everywhere in the spine from a fairly early age, and they don't mean a darn thing unless they are on the side and at the level that the physician knows matches a patient's symptoms, and then that disc protrusion is probably significant. We come now to the myth of the pain generator. This is the myth that is propagated by pain physicians everywhere. And this is the idea that back pain is caused by a single focus of pain, and that the idea is if you can just find that one thing, the pain will be solved. This is simplistic and extremely unrealistic. Spine, back pain, when it's just spine or back pain and not terrible arm or radiating leg pain, is never, ever, or very rarely one thing. If it were, we would be much more successful at treating it. The back pain is very complex, and that is because the spine itself is an extremely complex structure. The overwhelming majority of physicians who order MRIs of the spine do not ever look at them. They just read the reports. They don't look at them because they don't know how to. They are very complicated. It takes time and experience to learn how to read them. That's how complicated backs are. Back pain always has contributions from a number of interconnected spinal tissues. So let's talk now about the standard algorithm of treatment anywhere in medicine today. It starts with pain in the spine. Tonight we're going to say that it's low back pain, but it could be neck pain. You go to your doctor, you complain, or you don't bother to go to your doctor. You've learned that if you take 3 Advil 2 or 3 times a day for a couple of days, it gets better. particularly if you avoid building that stone wall that you've been promising your wife for the past 5 years, and you take a break from that. You get better. And if you don't get better, you go to the physician, and your internal medicine doc wisely says, well, heck, let's go see a physical therapist and or a chiropractor. And quite often, a couple treatments there and therapy improve things. But if it's still some persistent pain, certainly the internist will order an X-ray, and the X-ray very rarely shows the cause of back pain. It can sometimes, particularly in the setting of trauma and fracture, but if that's the case, then an X-ray should be had the first time you walk into a doctor's office. But if the X-ray doesn't show anything, as it probably doesn't, the next step is to get an MRI. Once you have an MRI, a pain doctor for sure is going to find something, and that something usually leads to a steroid injection, which is most commonly an epidural. And then if that works even in the slightest, chances are the pain doc's going to say, well, let's do it again, and let's do it again, and hopefully you're better. But if you're not, they're going to go searching now for the other sources of back pain. They're going to inject your sacroiliac joints. They're going to inject your facet joints. And whether or not those help or not, the next step in the pain physician algorithm typically is the radiofrequency denervation. This is burning the nerves, the treatment you may have heard about if you've ever been in this algorithm before. And this is where they burn something called the medial branch nerves, which supply sensation to the joints of the spine, which are assumed to be painful. When that doesn't work, you basically have a couple of choices. You either learn to live with it, or you go to a surgeon, and one of the surgeries they may perform is a discectomy, a laminectomy discectomy. And this is probably one of the more minimal procedures a spine surgeon performs. And this is also something that an MRI may show, oh, you have a disc protrusion, and the primary care refers you directly to the orthopedic surgeon. The orthopedic surgeon says, oh, you need surgery, so we can short circuit all of this, and you can go from the MRI straight to a discectomy. Now, if the discectomy doesn't work, the next step in terms of surgery is spinal fusion. And spinal fusion, unfortunately, leads to typically more spinal fusion. And after you've had a fusion or two, you may end up at the end stage condition, which is chronic back pain. And the treatment there is not good. It consists of narcotics, back braces, pain pumps, spinal stimulators. Not good. So what's wrong with the algorithm of treatment here? Well, drugs for one. Non-steroidal anti-inflammatory medications are fairly safe in the short run, but in the long run, they're really not good for you at all. They can cause GI bleeding and renal failure, so be very careful. Don't think you can take ibuprofen for weeks at a time. That's not a smart thing to do, particularly as we age. Steroids. This is the only thing insurance will allow a pain physician or any medical doctor to inject that's for reimbursement. Steroids. And steroids are not healthy to the body in any way, shape, or form. And epidurals, unfortunately, have never been shown to change surgery rates. So they really don't keep people away from surgery. They can make you feel better temporarily, but they don't last. And you have to do them again and again and again. And they really don't apparently change long-term outcomes, according to the data that we have. They also show decreasing effectiveness over time. The first time you do one of these, it can be a spectacular improvement, and patients will walk away thinking you're a genius, but that's just a steroid effect. You do it a second time, doesn't work as well. Third time, fourth time, you get to the point where they're not working at all anymore. Steroids weaken ligaments. They kill cells they come in contact with. They increase your blood sugar. They lower the immunity. They decrease your bone density. So steroids, especially repeated steroids, are a very bad idea. And then narcotics for pain, terrible idea. And I should not have to say anything more about that, as we as a nation are just coming out of a narcotic epidemic. RFD, radiofrequency denervation, burning the nerves. This is burning the medial branch. This is a schema showing the medial branch coming off of the main spinal nerve. And let's assume this is your lumbar spine as it is. And this is the nerve that goes down your leg. And of course, you need that. You don't burn a spinal nerve. But a twig off of the spinal nerve is this right here. It's called the medial branch. And as you notice, it sends a little twig to this facet joint and another little twig down to this facet joint. And the whole idea of burning the medial branch nerve, which is shown by a fluoroscopic view here, these are needles placed at 3 of the transverse junctions to burn the 3 medial branches on this side at L3, L4, and L5, is to take sensation away from a presumed painful facet joint. And that makes some theoretical sense. But the problem with it is that that it rarely works. And I speak from experience. I've done thousands of these, or I did thousands of these, and I can count on one hand the times that they actually worked. I stopped doing them because if you notice, this medial branch nerve twig disappears posteriorly, sort of vaguely. Where this little twig is going is to a muscle, and that muscle is known as the multifidi. And the multifidi are important stabilizers of the lumbar spine. And if you successfully burn the medial branch nerve out, the multifidi muscle that nerve is supplying at this level will disappear, atrophy and disappear, because muscles do that when their nerve supply is destroyed. So ultimately, when you're burning a nerve, whether you're successful at taking pain away from painful joints or not, what you've definitely done is destroyed important stabilizing muscles of the lumbar spine. So this procedure is a very bad idea, because if you take muscles away from the spine, you potentially have spinal destabilization, and I can guarantee you that's a state of pain in the spine wherever it occurs. Surgery, discectomy, laminectomy, discectomy. This is the most minimally invasive spine procedure there is. It's also known as microdiscectomy. It's called laminectomy discectomy because they have to remove some of a bone called the lamina to get into the back of the spinal canal so that they can move the nerves aside very carefully and remove the offending disc protrusion. And that's where the discectomy portion comes in. Now, this is largely successful at solving leg or arm pain. It is not nearly as successful at solving back or neck pain, and it does nothing to treat a degenerated disc. And any disc that herniates, by definition, is degenerated. And then there is such a thing known as post-laminectomy syndrome, which is a well-established syndrome in medicine. And this is the return of arm and leg pain after the surgery, sometime after the surgery, sometimes as quickly as a month or two. The arm and leg pain for which you had the surgery performed suddenly returns. And this is presumed to be scar tissue from the procedure entrapping the nerve. And unfortunately, at that point, there's not a whole lot doctors do except try to manage the pain. And it's not a happy situation. Spinal fusion. Spinal fusion destroys the motion segment, which are 2 vertebrae with a disc that connects the 2 of them. And when you destroy a motion segment, you've done a bad thing in the lumbar spine. Because if the good Lord felt that fusing 4 vertebral bodies together with screws and plates, as pictured here, was a good idea, he'd have designed your spine in that manner. Because what this does is it creates a huge block of bone that spans 4 vertebral bodies. This is a huge fulcrum, and it throws tremendous forces above the fusion level and below the fusion level. And this can create what we call transitional syndrome, where the level above the fusion and the level below the fusion break down, and you return to your surgeon, and your surgeon says, oh, we got to extend the fusion up, or we got to extend the fusion down. And this is what we mean when we say that fusion tends to lead to more fusion. Now, fusion's failure rate is quoted in the literature anywhere between 5 and 10%. But when you add that to the fact that it fails to solve back or neck pain in an estimated minimum of 20% of patients, you've got a rate of 35% here of lack of success. So you're failing a fair amount of time when you're doing this. So what's the alternative? What's the interventional regenerative orthopedic approach to low back pain? Well, for one thing, and first of all, and this is what drove me to stop being the pain guy, was that we preserve native spine structure and tissues. We're not burning out nerves. We're not shaving bone. We're not cutting out pieces of the disc. We're not doing any of that anymore. We're trying to solve your back pain by rehabilitating your tissues and thereby preserving them. Number two, we're treating the whole spine. We're not just focusing on the facet joints. We're not just focusing on the disc. We're not just focusing on a nerve. We're not just focusing on your muscles. We're treating all of that, plus your ligaments, plus your muscles. We're also using the body's ability to heal itself. And we'll discuss more of that, what that means in a minute. We're using only needles. We're not using scalpels. This is not surgery. So, number one, we preserve native spine structure and tissues. So that means that we're not doing repeated steroid injections, which destroy and kill important cells, which keep your cartilage and your ligaments and your tendons and your muscles and your bone healthy. We are not burning nerves and wasting muscles with radiofrequency ablations. We are not cutting out discs or bone with scalpels. We're not fusing one bone to another with screws and plates. We're not inserting spine spacers. This is a radiofrequency denervation. This is a spinal discectomy. This is inserting these spacers and plates in your spine to address stenosis. We're not putting pain pumps inside your spinal canal. What we're doing is we're going to treat the whole spine. We don't just treat its various parts. This is the piecemeal approach that's allowed by insurance. Insurance will not allow a physician to go in and treat the disc, plus the facets, plus a nerve, plus the ligaments. They just won't pay for it. They don't do that. That's not what they do. They have a very limited understanding of what causes pain in the spine. They don't quite understand that human spine is a very complex structure of interconnected parts, and you've got to treat interconnected parts if you're going to get a successful outcome. The motion segment, a vertebral body above, a vertebral body below, the disc in between. You notice the bones don't touch in front, the disc separates them, the bones touch back here in what we call the facet joint. This is the central canal. This is a hole out of which the nerves are coming. All the nerves are running up and down in the spinal canal for protection. Dysfunction in one of these segments will cause dysfunction in adjacent segments above and below. So it's very important to treat the dysfunctional segment. And when you do that, you've got to treat all of its structures. You have to treat the bone, you have to treat the disc, you have to treat the joints, you have to treat the nerves, you have to treat the ligaments that's holding all of this motion segment together, which are not shown here, by the way. You've got a ligament running down the front of the vertebral bodies, down the backs of the vertebral bodies, down the backs of the spinal canal, connecting the transverse processes, connecting the spinal processes. You have nothing but ligaments. And when you have a dysfunctional segment, one reason why it is probably dysfunctional is because it's loose and lax, and the ligaments need to be tightened up. Number two, we use the body's ability to heal itself. What does that mean? Well, we're using orthobiologics. That's a very fancy word, and what it means is we are using our patient's own repair cells, their own biological cells that we get from our patients, and we're using those cells to treat orthopedic conditions. Hence the term orthobiologics. There's two forms of repair cells in the human bodies. Platelets is one. This is a small cell found in the circulating blood peripherally. It's very easy to access. Its first job is to arrive at the area of injury and form a blood clot so you don't bleed to death. Its second job is to begin to secrete powerful repair hormones to repair the injury that it finds. The second form of repair cell is an adult mesenchymal signaling cell, otherwise known as MSCs, also known as stem cells. Where do we get stem cells in the human body? Well, they're in every niche of the human body. You've got stem cells in your brain, you've got stem cells in your liver, you've got stem cells in your bone marrow, you've got stem cells in the fat tissue of your body. In my world, we're talking about stem cells almost exclusively from bone marrow. Why is that? Because bone marrow stem cells have a particular ability to become the tissues of interest in orthopedics: cartilage, ligaments, tendons, and bone. Our spine care spectrum. Unlike other clinics, we inject all of the spine. We're injecting platelet growth factors around irritated nerves. We're injecting platelet-rich plasma into discs, joints, and ligaments. We're injecting stem cells into joints and discs. For those who have to run, I thought I would include a quick slide on how you contact the practice. Moving on. More about orthobiologics. We use platelet-rich plasma for joint cartilage. We use platelet lysate over nerves. We use platelet-poor plasma for muscles. And we use a combination of platelet-rich plasma and platelet lysate for small ligament tears. Bone marrow tends to be reserved, and we call it bone marrow aspirate concentrate, or BMAC. You can think of, stem cells when you see BMAC, but we call it bone marrow aspirate concentrate because that's what it is. We use this, I like to use this, exclusively for discs. I don't like to use PRP in discs anymore. I get better results with BMAC. We also use it for severe cartilage loss and severe arthritis in joints, and for large tears in ligaments in the spine. How do we do this? Well, these are precise injections of platelets and stem cells that we get from our patients into damaged, malfunctioning tissues. We're doing this with very advanced imaging, real-time X-ray known as fluoroscopy, and ultrasound, which are sound waves that we bounce off the soft tissues that show us the ligaments and tendons we're injecting. And when we put repair cells into these injured tissues, this triggers an acute inflammatory event that mimics an acute injury. And we get a near and far repair response. And that's all due to the fact that the body heals itself through an inflammatory cascade. And the minute we instigate inflammation in a structure, we get an immediate effect, and we get a long-term effect where the tissues, we have instigated tissue change in that damaged tissue, and hopefully it repairs itself. If we do this, get out of the way, protect the area by providing a little bracing, activity modification, good things can happen. You allow the body to repair itself. The body has to go through 3 phases: inflammation, which is probably the shortest phase, followed by proliferation of repair tissues. This is where a bunch of new protein is just laid down willy-nilly. And in this segment of improvement and repair, you want to avoid challenging the tissue. So basically, we shut athletes down. They can't work out. We have to put them in a swimming pool and exercise them that way so that they don't challenge the tissues we're trying to repair, and they can maintain some cardiovascular conditioning. And you make sure that a proper diet ensues. And the final and longest phase is remodeling of the tissue that's been laid down. And this is helped greatly by a return to physical therapy and a graduated therapeutic exercise program to stimulate the formation of mature tissue. What causes back pain? Well, this is quite frankly a billion-dollar question, because back pain is a billion-dollar black box in medicine. The one thing I can assure you, having been in the business for 20 years, is that it is never, ever, or very rarely just one thing. If back pain were one thing, it wouldn't be a billion-dollar industry, and doctors would be better at treating it. Backs are complicated. There are multiple contributors to any one back pain syndrome. You have to suss out just exactly what they are in your particular patient. But the potentially painful structures in the back are things that have a nerve supply, and they include muscles, ligaments, joints, discs, bones, and nerves themselves. Let's go through these rapidly one by one. Muscles. When you have muscular back pain, that's, you strain a muscle working out in the garden. That'll lay you up for 3 days to a week maybe, but some simple triage, ice, rest, ibuprofen, it's going to get better. And that tells you that it was just a muscle you pulled and no big deal. because muscles are not smart. They do one thing, they can contract only. And muscles contract to stabilize or splint a painful area. And often they're doing this because something underneath the muscles has caused some pain, and the muscles are trying to solve that painful situation by doing what they do, which is contract. But when they do this, they very quickly become a source of pain in and of themselves, because what can develop are called trigger points. And trigger points are just chronically contracted muscle tissue that begins to become necrotic and die. So trigger point injections can be very helpful for these areas, particularly if you have a really bad muscle strain that you haven't had any proper massage or electrical stimulation for. And trigger point injections right into that area can be very helpful. But as I said, muscles are reactive to pain coming from other spinal structures, and muscles are usually a downstream problem. But this brings up the issue of practitioners who are only able to treat muscles. You will often find, particularly if you're going back and back and back and back again to a chiropractor who's treating your muscles with electrical stim and massage, and you feel great at the time, but you don't seem to be getting better. That's a clue that the muscles are not the problem, that there's something beneath the muscles that needs to be addressed. The spinal stabilizer muscles we mentioned earlier, the multifidi. Here's a graphic picture of them. They're small muscles, but there's just tons of them, as you see. There's 2 at each level, and they're up and down the entire length of the spine, from your tailbone to the base of your skull. They are very important stabilizers of the spine. So when you burn them out, when you make them, when you destroy them by burning the nerves that supply the facet joints, you're doing a bad thing. It's not a smart procedure. These are 4 different pictures of atrophy of the multifidi. These are axial cuts through the lumbar spine. We're looking at a patient from their feet up towards their head. This is the disc in the middle. This is the sac of nerves. And this is the bone you can feel when you reach around and touch the midline of your back. This stuff, which looks like, red meat, is exactly what it is. That's muscle. That's powerful muscle. And the muscles closest to the bone are the multifidi. And you see that they're almost completely filled in with this red meat muscle. This is mild atrophy of the multifidi. You see the white around the bone? All right, well, that tells me when I see this, oh, you got some multifidi atrophy. This shows, there's a lot more white in here. You've got a lot more atrophy. This is a problem. We need to get you stronger for sure. And this is severe. You see, there's almost no muscle here. This is a real problem. What can we do about that? Well, physical therapy is what we can do about that. You exercise a muscle, it gets stronger, no doubt about that. And a stronger muscle is a less painful muscle simply because it can contract longer and is not as easily overwhelmed. We can also inject platelet, not rich plasma. I should have erased that. This is platelet poor plasma. We use this specifically to inject muscles. And there are small studies that show when you do that, you can stimulate the repair, the regrowth of muscles, particularly when combined with physical therapy. Ligaments, very, very important. Ligaments. Stability throughout the spine is key, particularly in the cervical spine where the spinal cord is located, but also in the lumbar spine where you've got all the nerves going down into the legs. This actually shows the ligaments. These are lateral collateral ligaments going up to the rib cage, actually. These are the iliolumbar ligaments going from the transverse processes of the lower lumbar vertebral bodies to the iliacus of the hip. I didn't want to do that. Let me go back. These are the intertransverse ligaments. So you see nothing but ligaments. This is the anterior longitudinal ligament that we're looking at, connecting the anterior vertebral bodies. Ligaments connect bone to bone, and the spine is held together with ligaments. Unfortunately, when there's no muscle involved, just ligament connecting a bone to a bone, physical therapy really can't help this because there's no muscle here. You can get a muscle stronger, but it's tough to get ligaments strong through exercise alone. As we age, our vertebral bodies settle, meaning the discs flatten out and the bones come closer together. And when they do, you can imagine that all these taut appearing ligaments become a little slack because the bones move closer together. And ligamentous laxity can lead to instability, and of course, instability leads to pain. So treating ligaments, getting them stronger, tighter, shorter, is very, very important. In addition to the fact that ligaments can be injured, and one of the perpetuating pain generators from a whiplash type injury, which is a prevalent term from chronic neck and back pain following motor vehicle accidents is posited to be microscopic damage to ligaments. So ligaments need to be treated, particularly in that situation, particularly as we age, particularly after traumas, and particularly when a motion segment is destroyed or falling apart. You've got to tighten up the ligaments to address that, to salvage that motion segment. How do we do that? We do that through a technique of injection known as prolotherapy. Now, this has been around 90 years. Traditionally, it was done with irritant solution, which was concentrated sugar water, dextrose. But what we do in my clinic is we inject your repair cells. We are injecting bone marrow. We are injecting platelets. But prolotherapy has been around a long, long time. This is not magic. It's not voodoo. It works. And what prolotherapy is a growth factor or growth factor stimulating injection. It addresses connective tissue insufficiency, CTI. That's a very fancy term and a very fancy way of saying your ligaments are too loose and your tendons are too loose and we need to tighten them up, or they're torn and we need to repair them. So prolotherapy strengthens soft tissues. It strengthens ligaments and tendons. And if you do that, you can very definitely increase stability. It also enlarges the footprint of where ligaments and tendons attach to bone. That's what tendon osseous junction means. This is a schematic of this picture here. This is an ultrasound a linear transducer. This is a syringe attached to a needle, which is being passed under that transducer. And this is the image that transducer is showing the operator. This is the needle coming in. This in cross section is the iliotibial band, which runs down the thigh and to the very distal knee. And the iliotibial band is being injected in cross section. If you rotate this transducer 90 degrees, you see the iliotibial band in long section, and you see the needle in short axis. That little dot there is the tip of the needle coming right at you, or coming right into the beam of sound waves. These are before and after pictures of tendons that have been treated with prolotherapy. Before, thin, after, much more thickened. Before, thin, after, much more thickened. As I say, prolotherapy was traditionally done with 12.5% dextrose solution, which is quite pro-inflammatory. And that works, but you've got to do it repeatedly. What we're doing now is we're injecting platelets and we're injecting stem cells using the same injection techniques of precise injections into ligaments and tendons to achieve the same results. Joints are pain generators. This is a schematic of painful facet joints in the lumbar spine. These are normal facet joints. They look nice and smooth. These are kind of cruddy looking joints. They're arthritic. They're like any other joint in the body. They're like a knee joint when it becomes arthritic. These can become painful. And you treat them exactly the same way. You want to stop the destruction of cartilage. And inside an arthritic joint, the cartilage has lost the balance between breakdown of cartilage and repair of cartilage. And mostly what's happening is breakdown of cartilage. And this is because the chondrocytes, which are cells alive in cartilage, are secreting enzymes that digest the cartilage. And what we do when we inject platelets or any blood product that contains human blood serum, what we're doing is we're inhibiting this enzymatic activity, which is digesting cartilage. Now, we didn't even know this up until about 10, 15 years ago, but all human serum contains powerful, powerful chemicals that shut down the activity of enzymes that digest cartilage. So if you did nothing else and just threw away the red blood cells and injected whole blood into a joint, you'd be doing a smart thing. Because what we're doing by doing that is changing the chemical microenvironment inside that unhealthy joint to a healthy pro-growth state almost immediately. And this is one reason why patients often feel better within a week of doing something like this. But what we're also trying to do long-term is stimulate cartilage repair, which will last for months to years. We also want to increase the joint stability. And again, we do that in two ways. We treat the static stabilizers, which are the ligaments, and we do that again with prolotherapy. We inject PRP into the multifidi. And we send you to physical therapy for those exercises, which we know are going to strengthen your core and increase lumbar stabilization through increasing muscle strength. This is a schematic of injection of a joint. It's very precise work. It's done under advanced imaging called fluoroscopy. It's sometimes very difficult to get into such a tiny structure. But the analogy of injecting an arthritic knee is exactly the same. You gotta get into the joint capsule and into the joint with the needle and inject your orthobiologic or steroid if you're the pain guy. Discs, these can be painful, but they're only painful in the posterior third. This is what a disc looks like if you're looking straight down on it. Again, this is sitting on a bone of the same shape, and this is the continuation of that bone, and this is the spinous process. Again, this is the bone you can feel in the midline of your back if you reach around and touch yourself. The disc is composed of a jelly donut type center called the nucleus and a tough fibrocartilaginous outer ring called the annulus. The anterior annulus has no sensation whatsoever. You could stick a hot poker into the anterior annulus and you'd feel nothing. But from here back, this annulus is very sensitive because it has a nerve supply. The disc acts as a shock absorber. It's a big cushion in between bones, and it distributes axial loads in the spine. It also acts as a spacer, keeping the ligaments really taut and the muscles separated and the openings for nerves that exit the spine nice and wide open. But with age, they lose water and they thin. They lose disc height, we call it. And they also lose their cushioning ability. And what this does is it increases load on the vertebral bodies, which can become painful. It increases perhaps irritation of nerves, which can cause arm and leg pain, and very definitely increases the load on the joints in the back of the spine called the facet joints that we just discussed, and that accelerates arthritic change there. This is a herniated disc. When the exterior annulus is compromised, you get a tear in it, you get some of this jelly donut center pushing out. And this can push on a nerve, as you see here, coming out of the spine. This causes that horrible arm or leg pain. If you've ever had it, you'll never forget it. Annular tears, we just discussed that. This is a tear in the annulus. This is a protrusion of a disc hitting a nerve. If there are protrusions in the posterior third of the annulus, they're potentially painful. Quite often you will see protrusions on MRI to the front. They mean nothing. This is an annular tear on MRI. It's a bright white signal in a dark disc. Discs should be light in color like this because the lightness on this series, which is a T2 weighted series, is water. And discs are mostly water in their center. This jelly donut center is mostly water. So they should have, and you see this disc is darker. So it's a more degenerated disc and it has an annular tear right here. That's presumed to be painful. Those have to be treated. How do you treat them? You inject the disc. You go in with high dose PRP, and there was a study put out in 2016, one of the earliest. 2-year follow-up showed that this was successful. You could do this. These are fluoroscopic views of a needle being placed in a disc, and the dark stuff is dye that's being injected into the disc to prove that you're there and to also to evaluate how disrupted the disc appears. Today, in my clinic, we use nothing but stem cells when going into discs. Why? Because we get far superior results. Nerves, of course, can be terribly painful. How do we treat nerves? Nerves can be irritated mechanically by a disc protrusion, as shown here. They can be irritated mechanically by narrowing of the passageways through which the nerves are exiting the spine. We call that stenosis. They can also be irritated not mechanically, but chemically. When you have a protrusion like this, if the protrusion isn't big enough to irritate a nerve in itself, the stuff that's leaking from the center of the disc is very pro-inflammatory, and that can cause nerve irritation and horrible arm and leg pain. And this results in that what's quite frequently described as a toothache-like pain in the leg or arm that you cannot escape, and it's associated with numbness, tingling, and quite often weakness. And it's just horrible. It's terrible, terrible pain. There is no worse pain than nerve pain. Irritated nerves send inappropriate signals to muscles, causing muscle cramping, and that's one way a doc knows immediately that it's the S1 nerve and not the L5 nerve, depending on what muscle in your calf is cramping. How do we deal with that? Well, we inject it with platelet lysate, and these are your platelets that have been lysed, meaning cut open. How do we do that? We put your platelets through a freeze-thaw cycle, and that destroys the cell membrane of this tiny little cell. And what we're left with is a soup of the contents of the platelets, which are filled with growth factors and repair hormones, some of which are neurotrophic, meaning they are specific to nerve growth and repair. The injection technique is identical to a steroid epidural. But we're not injecting steroids. We're injecting platelet lysate. The epidural space, by the way, is the space within the spinal canal here, between the bones, as seen here, and the nerves, which are covered by a membrane called the dura. And the space around the dura is called the epidural space. Any injection into the epidural space is called an epidural. It tells you nothing about what you're injecting into the epidural space. It just says you're injecting into the epidural space. So when we talk about pain in the spine, an epidural means we're injecting, if we're doing it under insurance, we're injecting steroids. If we're doing it in my clinic, we're injecting repair cells. There are studies out there basically obtained from registry data. This is patient-reported outcomes, that platelet lysate epidurals are superior to steroid epidurals. The functional rating index scores are higher, and the effects last longer than steroid epidurals. All right, that brings us to a case. Let's look at this. Let's pretend that we're in my office and a patient has come in with chronic episodic back pain with the much newer onset of terrible, terrible right leg pain. And we order an MRI, and this is what we see. Can anybody guess what we're looking at? This is the spine. Gray blocks are the bones. Black stripes, black and white stripes, are the discs separating the bones. This is the spinal canal containing all the nerves. What's that? That's a disc protrusion on the right at the L5-S1 level. It's also seen here, and this is to the right. So this protrusion is very significant. This is what's causing this horrible right leg pain in this patient. What else do we see? Well, we're seeing that the disc is degenerated here. This is a very black disc. We call this a dark disc. It's dehydrated, it has no more water in it. And I want to call your attention to the white in the bone just above the disc. This is called a modic end plate reaction. The bone is involved here now. And this is potentially painful when the bone gets involved with edema like this. So what else do we see? We see arthritis in the facet joints, left and right. The white stuff you see within these gnarly looking facet joints is fluid. That's a joint effusion. So that's an arthritic pain in the back. What else do we see? Oh, look at that. There's white in where there should be red. This should all be muscle. And there's some atrophy of the multifidi. You can see a little faint dark piece there. That's a remnant of the multifidi muscle. So we got to get the multifidi stronger. So how are we going to treat this? Well, the standard treatment in any orthopedics office that treats the spine would be potentially a right L5 transforaminal steroid epidural, maybe. Or if you're talking to the surgeon, he says, we got to do surgery. And you're looking at an L5-S1 laminectomy, discectomy. What's the treatment in my office? The orthobiologic treatment would include a right-sided L5 across the foramen, transforaminal, platelet lysate epidural. It would include bilateral L5-S1 facet injections with platelet-rich plasma. It would include L5-S1 ligament prolotherapy to stabilize this degenerated, disturbed motion segment and give it more support. PRP, platelet-poor plasma, into the atrophic muscles. And finally, of course, a return to PT to strengthen those muscles and to buy time to let the body repair itself. Here's another case, different case. Patient comes in with chronic back pain with leg pain. And funny thing, the pain is there only with standing and walking. He feels much better the minute he sits down. What's going on here? Well, here's an MRI of that patient. Again, we're looking in long axis. These are the bones, stripes in between of the discs, central canal. and this is the cross section through this level right here. And as we come down in the central canal, what do we see is, oh my gosh, look at this. It looks like there's a bottleneck. That's what this is. This is stenosis. This is narrowing. Stenosis is a fancy word we use for narrowing. The nerves are being squeezed. That's what all these tiny little dots here are. That's stenosis. And what we have here is an L4-5 spondylolisthesis. This bone doesn't line up with this bone. This is the L4 vertebral body, and it's slid slightly forward on L5. As you see that? And that's what's contributing to the stenosis at this level. And the fact that one bone has slipped forward on another tells me immediately, oh, we have instability at this level. You have incompetent facet joints, judging by these two gnarly looking facet joints. And that's what's allowing this bone to slip forward in this bone. So not only do we have to address the facet joints, we've got to tighten up the ligaments to keep this bone from slipping. And finally, we have this thick, dark structure on the underside of the canal. What is that? Well, that's thickening of the ligamentum flavum. And that, if you notice right here, is contributing to the narrowing inside the canal. So we got a lot going on. How are we going to treat it? Well, the traditional orthopedic treatment is epidural, epidural, epidural. If that stops working, well, let's try burning the nerve procedure, see what that does. If that doesn't work, then you're looking at lumbar spine decompression surgery, typically with fusion. That's the most common scenario here. What's the treatment in my office? Well, in my office, we're going to inject the ligaments, not once, not twice, maybe 3 times, maybe 4 times. We're going to do a lot of prolotherapy, particularly at this level where things are unstable and the stenosis is the worst, to try to reduce the stability and reduce the exacerbation of the narrowing centrally here. You've got to address the instability. So we do a lot of ligament work, number 1. Number 2, we're going to do platelet lysate epidural. We're not going to use steroids. We're going to do an epidural probably down here at 5-1 because everything travels north and we want it to be concentrated right here. We're also going to do bilateral facet injections into these gnarly arthritic-looking joints. And we're going to inject the ligamentum flavum to lessen the stenosis. Let's look at that a bit more. This is a schematic of the cross-section of the spine with a cutaway so we can see into the spinal canal. This is the ligamentum flavum. It runs all the way up and down the spine, attaching one lamina at one level to the lamina at the next level. When you look at it in cross-section on MRI, it's this dark, thick thing that's just in front of the facet joints. That's the ligamentum flavum. You see how thick it is? Well, if I very precisely and carefully place a needle into that ligament and inject it with some PRP, I can get that ligament to thin out a little bit. It will tighten up and be less loose and sloppy and contribute less to the narrowing. Now, we're talking micromillimeters here, but sometimes that's enough to take care of the painful narrowing inside the spinal canal. All right, we're just about to wrap it up here. Let's go back to the traditional algorithmic treatment of back pain, spine pain, let's call it. And let's look at the difference when you add orthobiologics to this algorithm. Everything is the same up until the point of the MRI. But at this point, if you're in my office, I may look at your MRI and say, hey, let's do an orthobiologic injection treatment. And this is a treatment that we can do after any one of these listed algorithmic treatments. If we do that, we're going to send you back to physical therapy. And with time and exercise, what can happen is resolution of back pain with preservation of native tissues. And when that happens, I'm happy, my patient's happy, we're all thrilled. Because what have we done? We have taken, I'm sorry, I'll discuss these in a minute. We have taken the patient out of the algorithm, which pushes him towards surgery and fusion and this horrible mess down here. We've taken them out of the algorithm altogether, and we've returned them to a life of pain-lessened, pain-free spine. That's the promise of what we do. How does this work? This is some registry data, and this is all comers. It's very crude data. This is all patient-reported outcomes. But you notice the time frame here. It's 4 years. And you notice the numbers. This is 4,700 patients. This is lumbar surgery success rate of 50% compared to all lumbar back pain patients that were treated with bone marrow aspirate concentrate or stem cells. And you see the success rate starting at 35% of functionality and increasing up to about 54%. So certainly as good as, if not slightly better than the surgery success rate. And this is very crude. This is all comers. And when we talk about surgery, we're talking about all surgery in the back. This is just the people who didn't go to surgery. This is the improvement they got. And as you see, it matches, if not exceeds, the rate of success of people going to surgery. Crude data, but nonetheless, some suggestion. This is functional improvement, again, in all back pain comers who were treated with bone marrow. This is the amount of, they were 49% of their function at baseline before they had their treatment. This is 7,500 patients. And if you follow them out 4 years, what you get is 71% of functionality, which is pretty good. It's a rise of, 20 points plus in functionality over time. And that's the impressive thing I want to call your attention to. This is 4 years. Finally, pain improvement. Average level of pain in the back was about 5 out of 10, 7,600 patients. Bone marrow in the back, follow them out over time. All patients, 4 years out, they've lost, oh gosh, almost 2.5 points in pain. And that's significant, definitely significant. And you have to understand that some patients don't improve at all. Their pain level doesn't change. In fact, some people's pain actually increases. And then other people's pain goes to 0. They have no pain. This is all average data for 7,600 patients. It's suggestive. And that concludes my presentation. And I want to thank you for hanging in there. That was a fairly long one. I don't typically do presentations so long, but that was a long one. So I applaud you if you are still watching. Thank you so much. This is how you schedule an evaluation. And this is my CV. And I would be happy to take questions if anybody has them. You need to type them in, and I will be happy to answer them once I read them. There's a lot of territory to cover, and I know that we kind of focus on the low back, and the reason why we did that was because majority of pathology is in low back pain, but it's followed very closely by mid back and neck pain. And the principles of treatment in my office are the same for the mid back and the neck. There are different instances or different prevalences of types of pathology. For example, in the lumbar spine, disc pathology is typically much greater than in, say, the cervical spine, where the forces just aren't as great. But arthritis tends to affect the neck almost as much as it affects the lumbar spine, et cetera, et cetera. But you can develop, facet joint syndrome anywhere in the spine. You can develop a herniation in any disc of the spine, pushing on a nerve, causing arm pain, leg pain, or wrap around the torso type pain. But our job in my clinic is to avoid destroying native tissues, try to preserve them, use the patient's repair cells to treat their spine issues, and avoid making a bad situation worse. Hopefully keeping patients away from spine surgery. Now, if you need surgery, I'll be the first to tell you if I don't think you're a candidate for what I do, or if we've tried it and given it a reasonable try and you don't respond. But that's the last thing you should be considering, because this is something that everybody should try before they consider surgery, if in fact they're even going to consider surgery. So we have a couple of questions. Curious on the quantity, how much stem cells in a typical injection? That's a good question. Studies have shown that you get your best result at above 400 million cells per microliter. So that's the dose we shoot for. And our harvesting techniques pretty much assure that we're always there. I only remember one patient and we didn't hit that mark, and it was quite surprising. It was a healthy, young, fairly young gentleman. He was in his 30s. And he came in at about 200. And he was on a statin and he didn't stop it. And we didn't catch that, which was our bad. So I did repeat the bone marrow procedure for them because of that, and counts were much better then. But that's the minimum count. With our harvesting techniques, we're quite often twice that and higher. Getting counts above 1 billion per microliter is terrific, and we sometimes get those. Next question. What is the average cost? Does insurance cover the cost? Insurance does not cover the cost, and that's a long discussion as to why. We've only been doing this in human beings since 2005. That is quite literally the blink of an eye in a very conservative profession such as medicine. And rightfully so. Medicine should be conservative. We want to do every newfangled, wackadoo, faddish treatment. But that's not what this is. The literature that we have developed to this point, 2005, so 20 years down the road, we have more literature on some of these procedures than we have on some of the standard procedures we do in orthopedics every day on the spine. And that's another lecture. I can quote you chapter and verse on the literature that's out there. So this is not voodoo. And those of us who practice it know that it's not voodoo. But it's explaining that to insurance companies before they'll cover this. I feel very confident that insurances will eventually cover this. Why do I say that? Because we all know that insurances are really about saving money and making money for their investors. And when they find out that injecting a disc is going to be quite literally a fraction of the cost of excising that disc and fusing that motion segment, which doesn't tend to work out anyway, they're going to jump all over this. Yes. So at the moment, no, insurance does not cover this. It depends on what we're doing. Spines are very complicated, and quite often I'm doing a lot. The most minimal spine procedure is probably a straight ahead platelet lysate epidural, costing anywhere from $1,200 to $1,500. If I'm adding facets and ligaments to that, you're looking at probably up to $2,500. If we're going into discs, that's the most expensive thing we do. And if we're going into discs, like I said, I like to go in with stem cells. That's approaching $5,000 per disc. And I don't ever just inject the disc. I'm then injecting ligaments around the disc. I'm injecting platelets. But of course, if you're spending that much money with me, you're getting a break. But these procedures can range up to $7,000, $8,000 if we're doing quite a few structures and multiple discs. So that's a ballpark figure. We don't have standard rates. We don't run the sales. This is something that you need to remember. I'm a medical doctor. I'm not a used car salesman, so I don't ever discuss money, and there is never, ever any point of sale pressure in my office. Heaven forbid I should ever be accused of twisting somebody's arm to do something like this. The way it works is you come in, I evaluate you. I do that under your insurance. It doesn't cost you any money. If I do think you're a good candidate, I will tell you how good a candidate. I will give you a rating, telling you whether I think you're a good candidate, a fair candidate, or a poor candidate. If you're a poor candidate, I'm going to tell you, you should probably consider doing something other than what I do. If you're a fair or a good candidate, I will send you a proposal, which will break down the costs, which you can review on your own. And I have you call me with questions if you have more. So that's how that works. More questions. Does Medicare cover this process? No, it does not. Have you treated patients with ankylosing spondylitis? You bet I have. I've treated a fair number of patients with ankylosing spondylitis. That's a tough condition. I know if you have it, how much pain you can be in. Are there risks going up into the neck? Absolutely there are, because at the level of the neck, when you're doing these procedures, you have the spinal cord there. And, spinal cord ups the ante. It makes what you do, you have to be very careful with what you do, of course. There are black swan events in the literature. Those of us who do this train for years to avoid them. But bottom line, typically, risk is very small. It's on the level of passing a needle through the skin. And whenever you do that, there's always a risk of infection, and that's the primary risk. If you're doing work in the cervical spine, if you're going near the spinal canal, you got to pay strict attention to where that needle is and where the spinal cord is. Yeah. So that adds a little complication to the neck, for sure. Is the initial evaluation covered by insurance? Yes, it is. We take all insurances. Have you treated successfully shopping cart syndrome? Yes, that's stenosis. I treat it successfully every day. Any age limitation? No. I have a 92-year-old female coming in tomorrow for treatment. This will be her second treatment in her spine. Does it hurt? Well, a smart aleck answer to that is it doesn't hurt me at all. No, it doesn't hurt. We take care to numb you. You're going to feel pricks and pinches with the needles in the back of your spine, even despite putting a topical local anesthetic on your back and your skin, because quite often I'm moving up and down a broad region of the spine and it's not possible to numb everything. But we're using what's called anesthetic grade needles. These are grades of needles that are on the level of a stiff wire. They're very, very thin. And following these procedures, typically, we don't hear great pain in the spine. Nowhere near the type of pain that we can hear from a knee or a shoulder that we treat in a similar fashion. Those can be quite painful. We give everybody a very short course of very powerful pain drugs, and my spine patients rarely take it. So that gives you an idea. These are not that painful procedures. No, even when we go into discs, yes, it's not that painful the following day. People do fine with these procedures. And I got to say, I love doing the spinal procedures. I love going into discs because I have a very high percentage of success doing this with chronic pain patients. This is an area where I have hit home runs repeatedly. So it's exciting for me. I urge you, if you have an issue and want an evaluation, get an MRI or come in, I'll order the MRI for you and we'll evaluate you and see if you're a candidate for what I do. Any other questions? I don't think so. I'll give it a minute. If anybody else wants to raise their hand, I'm happy to answer questions. Again, I thank you all for hanging in for such a long presentation. I typically go maybe a little over half this length. So I'm impressed that you all stayed. And I thank you again on the beautiful spring Tuesday in the Northeast for joining me. Looks like we might have one more question. Have you treated patients? Well, I answered that. Fascinating. Thank you. Well, thank you. How long does treatment last? Oh, well, that depends on what we're doing, what the pathology is. You know, we're shooting for permanence is what we're shooting for. In other words, I want it to last forever. Have I had people come back for more treatment? Yeah, I have. And when we're treating things that are intractable, like stenosis, that's something that people come back regularly for. Yes. And some people have chronic back issues. We will treat them quite often initially with a very involved procedure that takes a long time and is quite expensive. But then they'll come back for prolotherapy, which is a fraction of the cost and takes a fraction of the time. But we'll do that maybe quarterly for a year if I feel that the spine needs more stability. So it's hard to say how long that will last. Like I say, some patients I treat, they disappear. I bump into them in the supermarket somewhere and they, best case scenario, they're thanking me because it's years later and they're singing my praises because they're still good. What we're doing is trying to affect long-term change because we're trying to stimulate tissue change. I'm trying to repair discs, get them to repair themselves, repair cartilage and joints, make ligaments stronger, make muscles stronger. I'm trying to get nerves to repair themselves. When you're successful doing that, that's a long-term fix. Again, I thank you very much. It was a pleasure for me. I hope you got something out of it. Have a good night and take care. Bye-bye.